nursing was not necessarily an always a foregone decision. But I would tell people now that I don't see myself doing anything different.
Yeah.
I truly, I don't want to use the word calling because I think that we use that too much now in nursing,
Yeah.
that it's considered a calling, because then I think that allows people to then accept certain work situations and environments and things that I don't think are healthy for us anymore.
Yeah.
But I will say that nursing is a very good fit for me. And it
Yeah.
comes very naturally, very easily.
Hello, and welcome to the Art of Emergency Nursing podcast. This is where we share stories for inspiration, entertainment, and encouragement because we all know emergency nurses have the best stories. Now, here's your host, Kevin McFarland.
Hey everybody, Kevin McFarland here from the Art of Emergency Nursing, and thanks for listening to the podcast, and thanks for downloading this episode. I don't know about you, but I am just getting back from AOEN 23, and I had a blast. Hopefully you were there. If you weren't there, boy, put it on your bucket list to attend an emergency nursing conference because it is fantastic. You get a chance to meet people from all over the world who do the same thing you do, and you can talk about, your problems and your solutions and different things. Highly, highly, highly recommend going to a national emergency nursing conference or even just a local one. Local ones are great too, but the national is just an international conference, I should say. There's just something special about that conference. One of the things that I found myself doing as a podcaster is I find myself looking around the room thinking, okay, I got to interview them. I got to interview them. I got to interview them. And finding all these amazing nurses that I need to interview. And my list just gets longer and longer and longer. With that said, if you can think of somebody who I absolutely have to have on the podcast that I haven't had on the podcast before, or a topic you want to hear on the podcast, send me a message. Send me a message on either social media or hit me up, kevin@artofermergencynursing.com. Send me a message and let me know who you think needs to be on the podcast or what topics you'd like to see covered on the podcast. Remember, I have a second podcast called the How Not to Kill Your Patient podcast with Dr. Lisa Wolf. That one's a little bit more clinical, so sometimes the more clinical topics go there. But I'm open to some topics here on the Art of Emergency Nursing as well. So send me a message. Let me know what kind of topics and people you'd like to hear on the podcast. All right. With that said, I have a great episode for you today. Today, I have an episode with my friend Katie, who is amazing. You are going to love her. She is a nurse leader, a nurse educator, and absolutely amazing. One of my favorite people to see at the Texas ENA meetings all the time. You are going to love this episode with my friend Katie.
I'm Katie Wilson, and I have been an ER nurse since 2005. So what is that, like 18 years now? I currently work PRN in a local community ER and trauma center, and am also part-time clinical faculty for one of the local nursing schools here in Houston. And yeah, most of my career has been ER. I did do a brief stint in college health for about 3 years, where I worked as essentially the nurse manager for student health services at Texas A&M. But the rest of it has all been in the ER.
It's funny. An old mentor of mine did the same thing. He worked in the ER for years and years. And he went and worked for a college where he was like the manager of the college clinic.
And
And he did that for years and then eventually ended up going to the OR or something else. I don't even know what he's doing now. And he was like, that's the perfect job for an ER nurse because so much of the stuff is not necessarily emergent, but it's, just stuff that just having somebody who'd be like, oh, it's fine. It's not a big deal.
right.
Goes a really long way when, there may be people in there who are like, oh my God, this is terrible. And you're like, this isn't a big deal.
Oh yeah, I ran into that a lot. In fact, the kind of the unique thing, especially at Texas A&M, was that they have an on-campus student-run EMS service. They're one of the only ones in the country, but they have an ALS, like MICU level EMS service
Nice.
that does 911 on campus. And, then they actually then, do some cross cover with, local fire and EMS as well for areas around campus. But they're housed in the same building as the student health services clinic. And the whole reason why I even got that job was because my brother was at A&M at the time and was working for University EMS because it used to be volunteer. It was all students and they were all volunteers. It was so the physicians there, kind of had it a little cush in that if they had somebody that they thought needed to go for, higher care beyond the clinic,
They're like,
you know,
transport's right there. Ship out.
exactly. So they would so they could use, the EMS system to transport them because it was considered it was a covered by your student fee,
Yeah.
like that kind of thing. At least initially. A lot of those changed now. The student volunteers are actually paid now, but that was definitely an experience.
I bet.
I did get told by one of the physicians who was the, chief of medical staff at the time that I was not because I was an ER nurse, I was not qualified to be in the position that I was in. And told me that I was an EMT with nursing credentials. And I told him, I said, I'm not sure if that's an insult or a compliment.
Yeah, you're like, really felt about that.
And of course, and I also had to clarify to him that I was not an EMT. I've never been an EMS. Um, but it was definitely an experience.
I bet.
So
I bet. That's kind of cool. But most of your background's been mostly ER.
yeah, I started off as a new grad at University Medical Center in Lubbock after I graduated as an ADN at the local community college in Waco, where I grew up, and then moved up to Lubbock, started up there in the ER, and as a new grad, did my RN to BSN up there through tech, and then came back to Waco and started working at Scott and White in Temple in the ER there. Then moved to Bryan and took the job at A&M. And after doing that for about 3 years, and I decided that no, I really needed to get back in the ER and prove to myself that I could do what I had done before. And so I very specifically wanted to go back to work at a level 1 because my 2 previous facilities had been level 1s. And, wanted to prove to myself that I had not lost anything and I could go right back into what I'd been doing. And so I moved to Austin and started working at what was then University Medical Center Brackenridge, which is a level 1. It's now physically, Brackenridge does not exist. They tore down the hospital because they built a new hospital across the street, which is now Dell Seton, which is right there downtown. So I was there for about 3 years and then decided to move back to Bryan College Station and started working at St. Joseph's, which is a level 2 trauma center, and was there for about 8 years. And now I'm down in the Houston area. So yeah, so I've been all over the state. And,
That's cool. That's cool. And Houston's a whole different animal. Houston, there's so many hospitals.
oh yeah. Oh yeah.
So many hospitals. So I remember during COVID, like Houston, Houston was busy, but Houston never really got hit. And part of it is just because there's so many damn hospitals, just spread
Mhm.
it out. No,
Except for, we during COVID, up in Bryan College Station, we actually multiple times got transfers. Now, granted, most of them were, correctional patients, through
nobody else wanted.
their TDC. It's because, the hospital I was at, there's multiple TDC facilities around there. And we actually got several transferred up to us during COVID that, were coming from the other side of Houston.
Wow.
Um,
Crazy.
that because there was nobody that had space.
Yeah. Wow. That's crazy. So
So
what made
yeah.
you decide to go into nursing?
So there's not really a clear answer with that. I come from a family of nurses. My great grandmother on my mom's side was an LVN back in the day when it, was literally a country nurse working for a doctor in a small town in West Texas outside of Lubbock. That the doctor, owned the hospital, ran the hospital, and it was back when, as an LVN, that the doctor could provide your training and essentially write a letter to the board of nursing
Saying you can do all
testifying
this
to
stuff.
your right. And so she was, back in the early, about 1920s, was an LVN, and then my mom was a nurse as well. She graduated in the 70s, and actually one of her first nursing jobs was working in the burn unit at Parkland
Oh, wow.
back in about, I think she graduated in like 76.
Holy cow.
Yeah, and so she went to go work at the burn unit there. And so growing up, I was always compared to my mom because I sounded like her, I looked like her, so everybody was always, oh, are you going to be a nurse like your mom? And I was dead set on not doing that because
Sure.
I wanted to be, absolutely different from my mother. So I was like, no, I'm not going to be a nurse. My goal, I wanted to go to vet school. So I was dead set on going to vet school until in high school. Then I realized how much math I was going to have to do. And yeah, when I was struggling enough with calculus in high school, I was like, no, this is not doing this. So slowly, the idea of becoming a nurse grew on me. And, so about the time that I was a junior in high school, I had changed my mind, decided that's what I was going to do, that I was going to go to nursing school. And at the time, I was homeschooled. My parents had started homeschooling us when I was in sixth grade. And so at that time, the local community college, you could do dual credit. And
Nice.
so starting in like my junior year of high school, I knew I wanted to go to nursing school. I had decided I wanted to go to Texas Tech, and they had an entry option where that if you had all your nursing prereqs out of the way, you come in, you were done in 2 years. And so I started tailoring my dual credit classes in high school to meet the prereqs for the nursing program.
Good for you.
And when I graduated, I got into it as a high school senior and started off in nursing school out there in Lubbock at Tech and ended up not completing there. This is probably where I should have realized that I had undiagnosed ADHD, but I did not. And so I really struggled going from making that transition from high school to true college. The dual credit, the college courses I was taking in high school, I did great in, had A's and B's, but then it was, I think that transition to then being on my own and a different kind of course load and those kinds of things. And not knowing not knowing the right strategies to be successful with that. I ended up having to, move back home, transferred into the local community college, into their nursing program, finished there, and then did my RN to BSN afterwards. So yeah, nursing was not necessarily an always a foregone decision, but I would tell people now that I don't see myself doing anything different.
Yeah.
I truly I don't want to use the word calling because I think that we use that too much now in nursing
Yeah.
that it's considered a calling because then I think that allows people to then accept certain work situations and environments and things that I don't think are healthy for us anymore.
Yeah.
But I will say that nursing is a very good fit for me. And it
Yeah.
comes very naturally, very easily.
That's awesome. Yeah. It's one of those, okay, this isn't a calling, but this might be a calling, but don't push it.
Right. Right. So what I refer to it now is it's a passion. That nursing and, especially emergency nursing is a passion. Um,
Yep. You're right.
yeah.
It's a good way to put it. So tell me about a patient that changed the way you practice. Patient that you'll never forget.
I don't know if there's necessarily a particular patient, but I will say that because there's multiple patients that kind of put in my head, but I know that at least probably one of the biggest things that changed the way that I practice nursing and the way that I approached patients was working in Austin because that was the first time that I had truly worked in what would be considered like a county hospital and was really exposed to some different populations of people and really forced to look at some of my own opinions and perspectives and things. And I came away from my experience working in Austin. That truly was one of my favorite hospitals to work at because the people that worked there because they wanted to.
Yeah. Like county
You
hospitals aren't easy.
Yeah. But I loved it. And it really forced me to look beyond what the patient's complaint was and really be able to see, that person in front of me and start to look at some of the other circumstances surrounding why they were there and what they truly needed out of that visit.
Yeah.
That was my first experience really and truly dealing with patients who were, homeless or, dealing with significant mental illness, that really and truly what they were needing out of that visit was a little bit of human connection. And a lot of times, yeah, they just needed to eat.
Yeah. I always tell people, like, their chief complaint may not be their primary problem,
Right. Right.
right?
And learning to see that, it's not going to break the hospital if I let this patient eat on their way out. And one of the things that and that's not to say that all the staff at this hospital were this way, but there were definitely some people there that at the time I was not as jaded, but there were some people that didn't think that it was appropriate for us to feed somebody just because, if they're coming in just 'cause they're asking. And they would refer to it as, you're just giving them secondary gain. They're just going to keep coming back if you keep feeding them.
Yeah.
And it really, and that didn't sit well with me. And that's really where I think just kind of my approach to nursing started to change, in that it's not, feeding somebody is a basic need. And if this is where they're going to get their food, then, and we can provide it, then we can provide it. And it's not my responsibility to, quote, save the hospital, save the organization money by not giving this person who, quote unquote, doesn't deserve it because they're here all the time.
Yeah. How do you deal with those? I'll give you a perfect example. I was talking to this new nurse, this brand new nursing student who's worked in the ER as a tech, but she works with a lot of nurses that are a little bit jaded and sometimes aren't as kind as they need to be. And we had a conversation because I got a phone call and they were like, "Oh yeah, this guy's just a drug seeker," and I'm like, he may very well be a drug seeker, but he really does have a legitimate medical reason that he is in pain, and he clearly looks like he's in pain. Um, and just reminding that nursing student that, like, even though they may be a drug seeker, we're not gonna fix that today. We're not gonna
Right.
fix that in this visit. Um, but the reality is he's still in pain.
Right.
That
And
that basic
honestly,
human kindness.
I definitely got to the point where I was one of those jaded nurses. And there's still times it creeps up.
Yeah,
I don't think you can be in this for as long as we have and not
yeah.
have some of that to a certain degree. But I think it was a long process over several years, but really just, and I think some of it just comes with age and maturity. But I think that's also where, as an experienced nurse, that is now my responsibility to model that behavior so that younger nurses will pick up on that sooner.
You remember the first time you made a med error?
So I don't remember the first time I made a med error, probably because it wasn't a very significant one, but the most memorable one, yes, I tell this story all the time, especially to students and new nurses, because it happened as an experienced nurse. And I use it as an example of, it does not matter how long you have been a nurse. You still have to you have to do the same process. Let's see how long I'd been a nurse. I'd been a nurse at least 10 years when this happened. I know that. And I was doing a conscious sedation and with a physician, and we were using ketamine, and the pharmacy had recently changed the concentration of our ketamine. And so it had originally come supplied in, I don't remember exactly what it was to what it had changed to, but it had originally been a concentration that was not as concentrated. So you pulled up more volume to get what you needed. And I just, the vial looks exactly the same. The actual size of it was the same. And but I did not pay attention to the concentration. And so I pulled up what I thought I was pulling up. And so what I was supposed to be pulling up was 40. And what I pulled up was 200. Yeah. And I'm working with a physician that I'd worked with for a long time, and I give it, and this patient, when they say that ketamine doesn't depress the respiratory drive,
If you give enough.
if you give enough and you give it fast, it will for a little bit. And yeah,
He
and I should have, when I pulled it up, I should have recognized that I was that there was, like, not as much in the bottle. I remember having this thought in my head that's kinda weird, but I didn't pay attention to it. I didn't listen to that little voice in my head, and so I gave it, and yeah, and the patient immediately starts desatting and going out, and thankfully in the room
No.
is we had a paramedic student in the room with us who was right there and also kind of recognized what was, that the patient what was desatting. And so I had an extra set of hands to immediately start bagging this patient. Now, pressure never dropped. They never went bradycardia. Nothing else changed. And after bagging for about 5 minutes or so, then the patient came back up. So of course the doctor and I are both looking like like what just happened. And I look back over at my vial and I see it. And so immediately I just have this, like, your stomach drops to the floor and you're like, oh shit.
Yep.
I almost just killed this patient. I start shaking and I look at the doctor and I tell him, I was like, I gave him 200 ketamine. And he looked at me and goes, what? And I said, I gave him 200 of ketamine.
It's
And
like, so
oh
what
yeah,
do we
oh
do?
yeah. He looked at me and he was like, okay, let's, yeah. And
Okay,
so
we're gonna be bagging him for a little bit.
yeah. So I showed him what had happened. So he's okay. All right, we'll take care of this. And guy's shoulder popped right back in. That was the easiest part.
Oh yeah. Yeah, 'cause he was floppy.
Oh yeah, he was. Oh yeah, he was. So then I immediately am on my ASCOM calling my charge nurse and telling her, I was like, hey, I need you to come to this room. And so she knew I was doing a consultation. So she comes over there and she pulls the curtain. And so I tell her, I was like, hey, so this is what just happened. And later, when we were talking about this, she said she knew that something had happened because when she opened that curtain, she said, my face was as white as the wall. Yeah, because I was scared shitless. I
You're
was
like,
like, there goes my license. There goes, I've screwed myself. Yeah, we recovered the patient. He had to stay for a little while longer until we got him fully recovered. But his biggest complaint was that he kept saying that he couldn't see. It was because he had so much nystagmus.
I don't know, doink, 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 doink.
Yeah.
Oh man. Holy
Yeah, of course, and that was my first experience with that. Of course, I had to write myself up as far as writing an incident report and
Yep.
all of that and everything. And the director at the time of the ER that I was at, she was notorious for being there super early in the morning because this is when I was working night shift. And sure enough, she shows up at 5:30 in the morning and she's already read my report and everything. And she comes in and she's, hey, tell me what happened. And I tell her, exactly what happened. And this is what I didn't do, that I did not pay attention to my vial. I did not double check it. And she said, I've already had been working on a policy about there being double verification and for procedural sedation medications. And she's like, this just proves that we need this. And yeah, so out of that, then that was our policy went forward where that, you had to have two provider verifications. That had to be the nurse and the physician had to verify your dose with you. I think it had to be documented in the chart. And yeah, so I use that as an example. To this day, I tell nurses, I'm like, I am not embarrassed by the story. I'm not ashamed of it.
No.
It just goes to prove that you can be an experienced nurse and make a med error if you don't. And ever since, and I will tell you, it
You're
scared
all,
the shit out of me. And yeah, I look all the
yep.
time now.
Yep.
Even now in the new facility that I'm at, they scan meds in the ER, which is a new concept for me. I've worked places where they scanned on the inpatient side, but not in the ER.
Yeah.
And so I'm getting used to that. And I've already seen with some of the people that I've worked with, they just scan it and they're not paying attention to make sure that that what you're scanning is matching up with, they're just relying on the computer.
We get real comfortable just doing shit. We
Mhm.
get real comfortable like on autopilot.
Yeah.
Like, we get
And
on
that's
autopilot.
exactly what that situation
Yeah.
was.
And that's where the experienced nurses are going to make the mistakes. I have almost the same story for a conscious sedation. We were giving 2 meds. I don't even remember what 2 meds they were now. And I had my vials, I had my syringes mixed up, and I gave like double what I should have
Mhm.
given of one of the drugs. I don't remember which drug it was. Um, and respiratory rate falls, sat falls. We're like, oh shit, we got to bag this guy. So we're bagging them, and They're like, "What happened?" And I was like, "Oh," I'm looking at my syringe. I was like, "I just gave the wrong med. I gave too
Yep.
much of the wrong med." And the doctor was like, it's fine, we're good. Maybe just gonna bag him a little bit, maybe bag him up a little bit, see how he does." And yeah, he came back up pretty quickly, and we got the procedure done. So we're like,
Yeah.
"Okay, let's get the procedure done while we're here." Bagged him up, never, never to the point where he had to be like intubated or anything like that. You know, he was fine on a non-rebreather, yeah, pretty quickly. And sure enough, man, I walked out there and the doctor's like, "So what do we do now? What's the process?" And I'm like, "The process is I'm gonna go tell the director what I did. He's gonna write me up. We're gonna do an incident report and that kind of thing." So I go to the director. I'm like, "Hey, you need to write me up. I just made a med error." And he's like, "Did you like? Why would I write you up? Like, you gotta do an incident report, but I'm
Right.
not gonna write
Right.
you up for a mistake." He's like, "You're not gonna make this mistake again."
Exactly. And that is exactly what my director said. She goes, "I bet you're never going to do this again, are you?" And I said, "No, ma'am,
Yeah.
I'm not."
"No, ma'am. No, sir." And I said the same thing, "No." And, like, I'm always like, even when I hand meds to people, I'm like, "Hey, you gotta mix this. Hey, you gotta
Mhm.
don't give this one, give that one," but experienced nurses can get kinda cocky and be like, kind of on autopilot when they're doing things like medications, and that's what gets your patient into trouble.
Exactly. Exactly.
Yep, I know that for sure. So, that's a great lesson to teach people going forward that it's easy to make those mistakes. So, what's the best advice a nurse mentor ever gave you?
When I first started training as a charge nurse, the nurse that was rating me to charge, I had more years of experience than she did, but she had, obviously been charging for a while. And one of the things that she told me, which still sticks with me to this day, and is something that I have relayed to other nurses that I've trained to charge and that I do to students, is that if you keep your patient's safety at the forefront of your decision, so whatever decision you're having to make, if you're keeping patient safety as the priority, then you're not gonna go wrong. You're gonna be pretty
Hard to go wrong.
right. Right.
Yeah.
Whether that, and that doesn't necessarily mean that's what the patient wants. It's not saying that you do what the patient wants, but it's that if you make your decisions based on what is best for the patient's safety in that situation, then that it hasn't steered me wrong yet.
It's hard to go wrong if you kinda keep that in mind.
Mhm.
Yeah, it's hard to go wrong. It's hard to say, if you're always kinda keeping that safety piece in mind.
Yeah,
So,
and it's really thinking about safety as more than just what we think about, as far as, am I giving the right medication at the right time, those kinds of things. It's really thinking more beyond to, for instance, in a charge setting, what is the safest thing for my patients in this department at this time? Is it is it safer for me to keep this particular ICU patient down here and hold them because I have another patient that is even sicker that needs to go upstairs to get that one last ICU bed?
yep.
Is it safer for me to put that aggressive, combative patient in a room across from the nurse's station where I can see them? Those kinds of things. Or is it safer for me to go ahead and open up hall beds in my department and start pulling people in? And even if their wait time is still going to be the same as what it was sitting out in the waiting room,
Yeah.
is
They're
it
at
safer to
least
pull them back into the department and be in a hall bed and de-escalate some of the tension out in the waiting room?
yeah.
It's thinking beyond just the individual patient safety, or even the patient that comes in that, is it going to be safe for my patient to go home by themselves on crutches when the whole reason why they fell was because you know,
Like poor
they can't
balance or whatever.
right, they can't ambulate on their own anyway. Thinking about those kinds of things. For instance, just this last week, I had a patient that came in that had been in an MVC several weeks ago, and it had some, and was an older patient. It had some significant injuries. Was in a back brace and fell again. That they were, instead of using the walker, they were using a cane and ended up falling again, and this time breaking an arm. So now you have an older patient who's already unsteady, who's wearing a back brace, who now has a sugar tong splint on that's coming up past your elbow. And so it took two of us nurses to be able to get her up to go to the bathroom, just to be able to help her with everything because she can't use the one arm.
Yep.
And now but she's being discharged home. So thinking about what's safe for that patient, what environment are you discharging your patient home to?
I think sometimes we don't think about that as as an ER nurse. We think that's like somebody else's problem. But the
Right,
reality is there's a lot of patients that never go upstairs and, we're the nurse, the inpatient nurse, the outpatient nurse, and case management all rolled in one.
right, right. And that's why I told you, that's really kind of why I think I like emergency nursing so much is because you really are a jack of all trades.
100%.
Yeah, you really are. And I tell I've told newer nurses before coming into the emergency room that is sometimes when they express, kind of some, little disgruntled at having it not getting the exciting patients, and having to figure out how to get this one home again and those
Yeah,
kinds of things is really understanding is that our role as emergency nurses, we are public health nurses.
it's a good point.
And so you have to think about more. It's not just treat and street, which is what we have been taught for years is that because we are the primary access point of healthcare for a significant majority of the population now is that we have to think beyond just treat and street. You can't just discharge them out to the waiting room and tell them to get lost. Is that you do have to take that extra step and figure out how you're going to get your patient home and where that's getting social work, case management involved, which not every facility has that luxury of having those support services available. And so you learn I've worked at the last place I was at, we didn't necessarily have that. That was a day shift thing. And even then, the day shift in the ER for case management was a hit or miss.
Oh, 100%. Yeah. I mean,
So you really have to become that resource and you have to know your community resources, even as a staff nurse. Granted, as a charge nurse, yeah, I knew what those resources were and everything, but I had staff all the time that knew things that I didn't know.
yep,
Um,
100%.
so you have to become that resource for your patient.
Absolutely. What that's so true. It's just uh, saying ER nurses are like public health nurses is really a good way to put it because you really kind of, yeah, for a lot of folks that we are going to be their main access to healthcare.
Yeah.
So for the good or the bad, that's certainly not good. Um, but it beats the alternative. So great answer. One of the last questions I always ask everyone is a question called three things. And it's what are three things that an ER nurse should always remember? And what are three things they can just forget?
So I knew you were going to ask this question. And so I
Oh,
started
really?
writing some stuff down. It is hard. I was able to come up with three things to remember, but as far as forget, I don't know necessarily that there's because I feel like I've used it all at some point. Even like saying you can just forget nursing diagnosis, you can forget care plan. You really can't.
Yeah.
You may not formally use them as far as your documentation, those kind of things, but the concept, you still use the concept.
Oh, boy, you like Lisa Wolf would be like going like this. And wait till you become a nursing faculty. I have a whole new appreciation for nursing diagnoses and that
Uh-huh.
whole process and care plans. I was always like, oh, it's horseshit. I don't know anything about care plans. But after, about a year of doing clinical faculty, I'm like, I, I
Yeah.
understand now.
And it's realizing that you're doing it. You're
Yep.
just not recognizing that that's what it is. But yeah,
It's just not what we call it.
right, right.
Yep.
But understanding that no, you're still using them and you're still using the concept. Yeah, you can't forget those. But I will say, as far as three things to remember, one of them already touched on, but was that make all your decisions in relation to patient safety. That again, if you keep that at the forefront of your decisions, and you ask yourself, what is the best thing for my patient in this moment? And then one of the big things, and this took me a long time to really learn, and I had to learn it the hard way because that's why I left the ER originally after only being in the ER for a couple of years, is to learn to say no. You are not responsible for the staffing of the department. That department will run whether you are there or not. And you are not responsible for making sure that there is enough staff You
That's
have
a
to take you have to take care of yourself.
that's a hard one to that's a hard one for people to remember, but it's so critical because the reality is, like, when you're gone, the world still goes on.
Mhm. And yeah, the appeal of overtime is there, especially when as a young nurse, when you see how much money you can make, but then when you realize after doing it, it is realizing how detrimental it actually can be to you if you're not giving yourself enough time away from the job to actually decompress. And yeah, it's not your responsibility to staff a department.
Yep. You're 110% correct. And, I don't know how many times as a fairly new nurse, I worked one of my first shifts in the ER, and this is actually even before I was a nurse. I worked 11 to 11, and 11 to
Mhm.
11 are the swing shifts. Shout out to you swing shifters because, that's like the He-Man shift. It's busy the time you get there,
Yep.
and it's busy, when you're leaving, it's still busy. And
I did 3 to 3 for a long time.
same thing, like total He-Man shift of, the total you're gonna get your ass kicked the whole time you're there. There's no downtime. There might be sometimes in the morning, sometimes late at night. Sometimes late at night our ER will kinda taper down to, not as much. But when you're on the swings, you're busy the whole time. And
Mhm.
I remember I'd be trying to leave at 11 o'clock and I'd seen they were just still getting killed. And I'd be like, oh, I could stay for another hour. I could stay for another half hour. And a charge nurse named Jane Rich, who was just brilliant, she was always like, you know, the reality is, Kevin, if you leave in an hour, we're still going to be busy. If you leave in 2 hours, we're still going to be busy. It's, you can't stay all night and you're not going to fix it. You're not enough. And, you're like going, it's a good point.
Yeah. That was a
So
situation I found myself in after only being in the ER for a couple of years was that, working 3 to 3 is that, then at 3 o'clock you would, or getting close to 3 is that they're coming and begging you to stay till 7.
always.
And it got to where, and I didn't know how to say no.
Yep. Yeah.
Yeah. Yeah.
Yeah. It's hard. It's hard. And I see it all the time. And you see the new nurses. I remember we had a nurse residency and the nurse residents be like, hey, when can I start working overtime? And you're like going, there's plenty of time for overtime. Like you
Mm,
don't burn yourself out the first year you're out of school. You're going to kill yourself.
exactly. And then I'm kind of then along in the same vein is that, the other thing is that it's only 12 hours. Is to remember that it's only 12 hours.
Yep.
The shift will end.
One way or another.
It will end and you will get out of there. But yeah, but it's only 12 hours
Yeah.
and you will survive. Um, but I will say that in addition to that, one of the things that I've learned, and again, it took me several years and I had to learn it the hard way. But one of the things that we're getting better at it, but one of the things that we don't teach in nursing school, we don't teach new grads when they're coming in on orientation is taking care of your own mental health. That and when I say what I mean is that we, especially as emergency nurses, we experience a significant amount of secondary trauma. And we're not taught how to process that. And a lot of times they're not given the opportunity to process that at work. And there's definitely times where you can't do it immediately. You have to go on, you have to take care of what's in front of you. And that's where the after shift debrief sessions that a lot of us end up doing. The sad thing is that, you see a lot of heavy alcohol use,
Mhm.
which is not great. But at least the getting together with the people that you've been on the shift and having that time to talk through the night or the day or whatever you experience, but having those relationships, somebody that you can talk to that understands the job,
Yep.
and but taking that time for yourself and acknowledging that yes, you are affected by and the patients that you treat, that we are not, there's this idea that our nurses are the badasses that have, these hard exteriors that nothing bothers us, nothing phases us. We can deal with anything. And I think what ends up happening, at least in my case, what ended up happening is that spilled over into my personal life. and into home. And so then it affects the way that you interact with family members, and it affects the way that then you process your own personal experiences. For example, my mom was diagnosed with breast cancer when I was in nursing school, and
Yeesh.
then died 6 months into my first job as a new
Wow.
grad.
Oh,
And I took 2 weeks. I took 2 weeks off
yeah.
before I went right back.
Yep.
And because, my mindset was that we knew this was happening, we knew this was coming, and this happens to other people. And nobody, even like my director, my man, nobody even told me that it was okay that I could take longer.
Yeah.
And so then fast forward to then a couple years later, then my brother was killed in a gun accident. And even though the circumstances were different between those two situations, I went right back into that same like almost like clinical, like unemotional state, where you just deal with it clinically and you don't deal with the emotions, you don't process any of it.
Yep.
And I did do some great counseling after he died. And what was interesting to me was, honestly, the issues that I ended up dealing with during all that weren't related to his death. They were related to my mom, because I hadn't taken that time in those 2 years to process all that.
Yep.
And now that was also one of the things that when I left the bedside in January of 2021, and I tell people that I left mainly because it was mainly I was getting married and I was moving to a different location and those kinds of things. But at the same time, it was also because my husband had recognized that COVID really was the straw that broke the camel's back. In that it wasn't just that once a week or once every 2 weeks that I would have a really bad shift.
It was
It
every
was
shift,
every shift.
and every shift fucking sucked. Oh,
Exactly. And so I have used those 2 years that I've been away to actively go to therapy and
good for
work through
you.
a lot of that has been related to that secondary trauma that we experience. And I think that talking about it like this is one way that it helps destigmatize that it's okay after a tough patient. If a patient makes you cry, that's okay.
Yep.
That
Right.
just shows that you're human.
Yep. You're 100% right. And we are gonna have emotions, and we can't deny that.
Yeah. And I think that's part of the piece of that puzzle of why so many nurses are leaving, is that we, as a profession as a whole, not just, emergency nurses, it's nursing as a whole.
We just don't deal with it. We
No.
just don't deal with it, so it just festers.
Right.
Yep. Did you see that? Did you see the video I posted in the ER Nurse Tribe group?
Oh, excuse me. Today?
Yeah, I think I posted it last night.
I think so, maybe. Oh, the one, yes, where it was asking, what do you tell your friends when
Yeah.
yeah. But then, okay, so what do you tell yourself?
You're like,
No,
you're like,
bottle it,
"I like
bottle
that.
it up, pack it down,
I like
pack
that.
it down.
Now I gotta talk about it."
Exactly. Exactly. That's exactly what we do.
And I seen that video and I'm like going, "Oh my god, that's like every ER nurse I know." Like, I watched that video and I was like, "I feel attacked." This is this
Right.
I'm like going, "Oh man, this is I
Yeah.
100% feel this."
But again, I think that's where, as experienced nurses, I think that that's part of our responsibility, is that those of us that have learned that lesson, is that right, is share that lesson. Don't hold on to it. It's not going to do you any good to hold on to the lesson and watch somebody else suffer and go through the same thing.
Yep,
Yeah.
yep, 100%. And it's one of those where you're like, yeah, you just have to always preach that, because it's one of those things that, like, everyone goes through it. Every
Hmm.
single one goes through it.
Yeah. And another piece of that too is understanding how your own personal trauma and grief and experiences affect, then how you interact and treat those and understanding how that's going to affect you.
It affects everything. It affects
Yeah.
everything. Like, one of the things that I'm always reminded is that, like, your experience is gonna shape how you treat people. And, if the perfect example, I remember one nurse being, like, super shitty about patients who are addicted, and you're like going,
Mhm.
and I was like, "You have issues here around this issue." Like, there's this like a normally
Yeah,
very
and
sweet
that's
nurse was like going, like I was like, "When it comes to addiction, you really have
yeah,
a bias. Like, you are like, oh, you drug addict, you this, you that."
yeah, and, that's something that personally that I had to deal with, because so my husband is a recovering alcoholic, and that was something that before I met him, like, I most certainly had an attitude about that of that, if you really wanted to fix this, you would do it.
Ain't easy.
And it's not until you have that personal experience with somebody and the dynamics of that and understanding that, yeah, there's more to it than
Yeah. You never know somebody's story.
you never know somebody's story. And I really and truly have learned that through the people that I've met through ENA. And you get to know people and you hear their background and their stories and
Oh,
yeah.
they got some stories.
Oh yeah.
They got some yeah, it's you just you never know, and if you just treat everybody with a little bit of kindness and compassion, that goes a
Mhm.
really long way. Well, holy cow, this has been a lot of fun. I really appreciate you taking the
Yeah.
time to do this with
Yeah.
me. I've taken up way more of your time than I expected, but this has been a lot of fun. It's good to
Yeah.
catch up with you and talk to you, and
It really was. So
so
yeah, when you messaged me from the happy hour, I was like, "Oh, well, okay. If you
it's
want to talk,
like,
I don't know what we're going to
yeah,
talk about, but okay." Think-
it's but one of the things I've really loved about doing this podcast is getting a chance to get to know people that I know, but I don't know their whole story. I don't
Yeah,
know
yeah,
everything, and getting to know them a little bit better, and just sharing these stories. It's just super cool to me. It's just cool to be able to get that voice of what goes on in the emergency nurse's heart and head,
mm,
there, and try to share that a little bit. It's kind of cool. So
I enjoyed it.
it's been fun. Yeah, it's been a lot of fun.
Thanks for listening to the Art of Emergency Nursing podcast. Make sure to subscribe to the podcast and follow us on Facebook.